So the objectives of this lecture will be to discuss and summarize available evidence investigating antiviral therapies for COVID-19, and to discuss and summarize available evidence investigating pharmacologic supportive therapies for COVID-19, and to present the NIH, or National Institutes of Health, and some of the IDSA recommendations regarding these therapies. So since there's just a breadth of information and multitude of data coming out regarding COVID-19, and not to mention all the political drama and all the socio-economic implications of this pandemic, this lecture is meant to summarize available evidence-based literature investigating pharmacologic therapies for COVID-19. So again, this is not like an in-depth journal analysis or a journal club or a detailed discussion, but more of just a rundown of what we know so far about these pharmacologic therapies. And again, I'd like to emphasize pharmacologic therapy so that we will be focused on this specific area about COVID-19, and hopefully we do not digress to other questions about other areas about this disease, such as prevention, diagnostics, clinical manifestations, or the non-pharmacologic interventions. So again, COVID-19 is still an evolving and dynamic topic. So this is just like a cross-sectional view of the evidence that we have to date, and it is not meant to be final at this time. So hopefully this lecture can summarize some of the highlights of this academic year as we head to another academic year, and maybe this lecture can also be used to transition incoming trainees into the topic of discussing COVID-19. So this is a good figure that depicts the various stages of COVID-19. While there is still some considerable overlap, it can be divided into 3 distinct stages. So you have stage 1, where you have the early part of the infection, which occurs at the time of inoculation and early establishment of the disease. Sorry. Okay. And it is at this time, for most people, this involves an incubation period associated with mild and often non-specific symptoms, such as your malaise, your fever, your dry cough. And it is during this period that SARS-CoV-2 multiplies and establishes residence in the host, primarily focusing on the respiratory system. Stage 2 becomes the moderate part of the disease, that has like the pulmonary involvement, that is divided into either stage 2A or stage 2B. And the difference between stage 2A and stage 2B would be the with or without the presence of hypoxia. And lastly, your stage 3 is the host inflammatory response phase, wherein the patient would then enter into like this hyperinflammatory phase, and resulting into some systemic inflammation and your hypercoagulable state. So, using that slide, I pretty much divided some of this lecture into 3 big groups of pharmacologic therapies that are being investigated at this time. So this is my main reference for this lecture. This is the website of the American Society of Healthcare Pharmacists. You can pretty much access, I have the link available in the notes section of this presentation. And the evidence table, their evidence table is pretty much my big reference, because they pretty much gave a good summary of all the best available evidence that are going on at this time, especially, and they also list down the current trials that are already being listed in clinicaltrials.gov. They also update the evidence table weekly with new literature that comes out every week. So it's also a good way for you to get updated with the literature that's constantly evolving. This is the master slide. This master slide shows the big list of all the therapies that are being investigated at this time. Those that are in blue are the ones that I've included in this lecture. So let's move on to the big part of the presentation. So We'll start first with this big group of the antiviral agents, and they are listed on the right side of the screen. You have hydroxychloroquine, remdesivir, HIV protease inhibitors, and the antivirals that have been approved for use against influenza in other countries that may or may not have some activity against SARS-CoV-2. So let's move first to, this is a figure that depicts a good summary of how they view where these where exactly in the life cycle of the virus that these antivirals can act. I got this from Sanders et al., which is like a JAMA review article of the pharmacologic antivirals that are being investigated. So starting with hydroxychloroquine, so the mechanism of action against COVID-19 is not really fully understood, but it has been demonstrated to have some antiviral activity to some of the coronaviruses. Its mechanism of action, they suspect it may change the pH at the cell membrane surface and inhibit viral infusion. It can also inhibit nucleic acid replication, glycosylation of viral proteins, as well as viral assembly and release. So hydroxychloroquine may be more potent than chloroquine in vitro, and it has some immunomodulatory activity that theoretically could contribute to an anti-inflammatory response in patients with viral infections. So it can work on both the stage 1 phase and also the stage 3 phase, theoretically. However, hydroxychloroquine has more, as we all already know, the side effects of the chloroquine has like a prolonged QT interval, and hydroxychloroquine being the same structure as chloroquine can also have that side effect. But they are assuming that hydroxychloroquine has a more favorable dose-related toxicity profile than the chloroquine. So there are various dosages recommended for or being investigated for treatment of COVID-19. For the emergency use authorization of hydroxychloroquine, the dosing is at 800 milligrams on day 1, then 400 milligrams daily for 47 days of total treatment based on clinical evaluation. There are several trials that is exploring on hydroxychloroquine combined with azithromycin, and the studies in France by Gautret and Million was the first to try to investigate whether hydroxychloroquine can exert an antiviral activity to COVID-19. Their dosing in the France study used 200 milligrams 3 times daily for 10 days with or without azithromycin. And azithromycin is dosed as 500 milligrams on day 1, then 250 milligrams once daily on days 2 to 5. In general, the clinical experience regarding hydroxychloroquine, majority of data to date involves use in patients with mild or moderate COVID-19, and there's only limited clinical data on use in patients with severe disease. More recently, this study came out by Mira and her colleagues. It was a large multinational retrospective study that analyzed outcome data for hospitalized patients with confirmed COVID-19. This data were for 96,032 patients hospitalized with COVID-19 between December 20, 2019 and April 14, 2020. And this collected data from 671 hospitals worldwide. The conclusion from this study, as I summarized in this table, was that after controlling for multiple confounding factors, treatment with hydroxychloroquine or chloroquine with or without a macrolide was independently associated with an increased risk of in-hospital mortality and was independently associated with an increased risk of de novo ventricular arrhythmia during hospitalization. There was also evidence that the risk of de novo ventricular arrhythmia is increased when hydroxychloroquine or chloroquine is used with a macrolide. So because of this was a landmark study, I believe, recently that came out on May 22, and because of this, there was this was the big evidence that proved that that the side effects were of great risk to the patient. And because of this, so a lot of the hospital systems in the world have already started to remove hydroxychloroquine from their protocols. However, just yesterday, the Lancet issued a retraction of this study, citing that that the investigators were unable to complete an independent audit of the data underpinning their analysis. And as a result, they have concluded that they can no longer vouch for the veracity of the primary data sources until the company, the investigational company that handles their data, that collects the data, their database is able to give them a more clear analysis or will allow a peer review analysis of the data. So this was fairly something that happened just yesterday, I believe. So I don't know yet how this is going to change again, how people are going to view hydroxychloroquine at this point. So just some take-home points regarding hydroxychloroquine. The NIH COVID-19 treatment guidelines panel states that clinical data are insufficient to recommend either for or against use of hydroxychloroquine for the treatment of COVID-19. IDSA recommends that hydroxychloroquine be used for the treatment of COVID-19 only in the context of a clinical trial. So with regards to using hydroxychloroquine with macrolized, NIH recommends against the use of a combined regimen of hydroxychloroquine and azithromycin for the treatment of COVID-19, except in the context of a clinical trial. IDSA recommends that a combined regimen for the treatment of COVID-19 should only be used in the context of a clinical trial. And as of this time, NIH still does not recommend the use of any agents, including hydroxychloroquine, for pre-exposure prophylaxis or post-exposure prophylaxis for prevention of SARS-CoV-2 infection outside of clinical trials. Let's move on now to the next antiviral that's holding the most promise.
Greg?
So yes.
Sorry, one comment raised from the audience by Dr. Sita Lakshmi. I'm just going to read her comment. The paper that you just presented is in the process of retraction from Lancet due to data impropriety.
Yeah. Yeah, that's what I said. Yeah, that was the.
Pointing it out. Yes. It came out yesterday, and you did a great job. I'm so glad you pointed that out. You're right. Everybody thought this was a landmark study, and a lot of protocols, including ours, we were getting hesitant to keep hydroxychloroquine on it. But it kind of goes to show you how much pressure there is for publication, and even reputed journals like Lancet, to think that they did not have COVID-19 ICD codes or some kind of coding data. So the primary outcome was based on chart extraction with no COVID-19 coding data. So how was that primary outcome collected? So that was the biggest worry with this study. So thank you for pointing that out. I think you did an awesome job pointing that out. Thank you.
So let's now move to, thank you, Dr. Lakshmi. So let's now move to Remdesivir, since that's the antiviral now that holds the most promise. So the mechanism of action of Remdesivir, it's an adenoside nucleotide prodrug that is metabolized to the pharmacologically active nucleoside triphosphate metabolite after being distributed into cells. The Remdesivir triphosphate then acts as an adenosine triphosphate analog and competes for incorporation into RNA chains by the SARS-CoV-2 RNA-dependent RNA polymerase, which then results in delayed chain termination during viral RNA replication. In other words, it's an RNA polymerase inhibitor or competitor. It has a broad spectrum antiviral activity with activity against various viruses, including coronaviruses, and it was even investigated for Ebola and even SARS-CoV-1. So in vitro, there is some in vitro evidence of activity against SARS-CoV-2 in Vero E6 cells, but clinically it is yet to be still determined whether it does exert a clinical benefit. So the optimal dosage and duration of treatment is not yet known regarding Remdesivir. The emergency use authorization dosage recommended for adults and children weighing 40 kilograms or more is as follows. Loading dose of 200 milligrams by IV infusion on day 1, followed by 100 milligrams infusion daily for days 2 to 10, and the duration is dependent on whether or not the patient requires or not does not require mechanical ventilation or ECMO. So for patients who require invasive mechanical ventilation and or ECMO, you give the remdesivir for a total 10-day course. But for patients not requiring mechanical ventilation and or ECMO, total duration of the treatment is only for 5 days. So criteria for emergency use authorization for these for using remdesivir, I got this from the FDA as well. Hospitalized adults and children with suspected or laboratory confirmed COVID-19 who have severe disease, and severe disease is defined as oxygen saturation 94% or lower on room air or requiring supplemental oxygen or mechanical ventilation or ECMO. The only individual compassionate use now that's being reviewed would be for the use of remdesivir in pregnant women and children less than 18 years old with confirmed COVID-19 and severe manifestations of the disease. And just recently, they also, this trial called the NCT 04302766 is just recently opened this week, wherein they are allowing compassionate use access for Department of Defense personnel through treatment investigational new drug protocols. And this is sponsored by the U.S. Army Medical Research and Development Command. So I guess this is also something that the VA people will also be looking into at this time. So some of the clinical evidence regarding the use of remdesivir. This was the initial study in China, wherein it was a randomized double-blind placebo-controlled trial in hospitalized adults with severe COVID-19. They were patients were randomized 2:1 to receive remdesivir or placebo, initiated within 12 days of symptom onset. Their primary outcome was to see whether there was what was the median time to clinical improvement. But their conclusion was that the median time to clinical improvement was not significantly different in remdesivir group versus a placebo group. And there was no difference in the 28-day mortality rate as well. However, some limitations with this study was that enrollment was terminated before the pre-specified number of patients was attained, and the trial was insufficiently powered to detect assumed differences in clinical outcome because of this. So this then led to other more larger trials. And there's this phase 3 randomized open label trial that's now ongoing in hospitalized adults with severe COVID-19, which is currently sponsored by the manufacturer, which is Gilead, to evaluate the safety and antiviral activity of 5 and 10-day regimens of remdesivir. And preliminary results of preliminary analysis from this trial shows that the time to clinical improvement for 50% of patients shows that it's around 10 days in the 5-day treatment group and 11 days in the 10-day treatment group, showing that there's no difference really with that, and it can vouch for a 5-day course instead of a 10-day course of the drug. This study also showed that the achievement of clinical recovery at day 14 occurred in 64.5% in the 5-day group and 53.8% in the 10-day group. So technically, there's no statistical difference between whether or not you give a shorter or longer duration of remdesivir for severe COVID-19 patients. Another trial was was under the NIH. This was a phase 3 adaptive randomized double-blind placebo-controlled trial. Again, with hospitalized patients with COVID-19. This trial involves 1,063 patients randomized 1:1 to receive remdesivir, plus, of course, standard of care or placebo. And from here, this was the study that was published in NEJM. And this study had found that 88.7% of patients who had severe disease at study enrollment, and the median time from symptom onset to randomization was 9 days. So it does have some clinical benefit of shortening the duration of the disease. So preliminary data analysis that included 1,059 patients indicated shorter median time to recovery in the remdesivir group versus the placebo group. And there was also, from this preliminary analysis, there was also a survival benefit with Kaplan-Meier estimates of mortality by day 14 were 7.1% in the Remdesivir group versus 11.9% in the placebo group. So some take-home points regarding Remdesivir. So far, this is the most promising direct-acting antiviral currently being investigated for COVID-19. However, it's not commercially available, and you'll have to go either through the emergency use or compassionate use for it. So NIH COVID-19 treatment guidelines panel recommends the use of Remdesivir for the treatment of COVID-19 in hospitalized patients with severe disease for now. They don't recommend it yet for the treatment of mild or moderate COVID-19 outside the setting of clinical trials. So next next group of antivirals being investigated would be your HIV protease inhibitors like your Lopinavir-Ritonavir or Kaletra, and there's also Darunavir. So regarding Kaletra, this was a randomized, the first study that was investigating this was this randomized open label trial in China by Cao and her colleagues. It compared Lopinavir-Ritonavir plus standard of care versus standard care alone in hospitalized adults with severe COVID-19 with their primary endpoint of time to clinical improvement. In their intention to treat population, their time to clinical improvement was not shorter with Lopinavir-Ritonavir compared with standard of care. And they found no significant differences in reduction of viral RNA load, duration of viral RNA detectability, duration of oxygen therapy, duration of hospitalization, or time from randomization to death. This then led on to other more trials investigating Kaletra. This was another trial done in China by Huang and his colleagues that investigated Lopinavir-Ritonavir versus chloroquine in this small randomized study of 10 patients. Their conclusion, chloroquine was associated with shorter time to RT-PCR conversion and quicker recovery than Lopinavir-Ritonavir. And however, the limitations of this study, they included only a limited number of patients, and the median time from onset of symptoms to initiation of treatment was shorter in those treated with chloroquine than in those treated with Lopinavir-Ritonavir. So again, it comes again with this debate about the appropriate timing of when to give these antivirals, whether it's because theoretically you should be giving it earlier on in the course of disease, like in the same concept as giving antivirals for influenza, so that you can decrease the decrease the incubation period and also the time to reach a heavy viral load. There are now several other open-label trials done in other countries outside of the US that still investigates other HIV protease inhibitors, and most especially like Darunavir. These are some of the trials that were listed, that are listed currently, and they're all done being done in China or Thailand. So take-home points for HIV protease inhibitors. The dosage of Kaletra that were given in these studies, it's 400 milligrams of Lopinavir and 100 milligrams of Ritonavir given twice daily for 10 to 14 days. The NIH treatment guidelines panel recommends against the use of Lopinavir-Ritonavir or other HIV protease inhibitors for the treatment of COVID-19, except in the context of a clinical trial. IDSA recommends that Lopinavir-Ritonavir be used for the treatment of COVID-19 only in the context of a clinical trial. As we will move further with the support, as we discuss the supportive therapies, there are also some other trials going on that uses combination therapy with Lopinavir-Ritonavir plus or minus other investigational therapies like Interferon beta-1b and Umifenovir. Moving on to the next antiviral being investigated, it's Favipiravir, or brand name Avigan, or other generic names that it's known for in other countries will be Favilavir. So the mechanism of action is similar to Remdesivir, being an RNA polymerase inhibitor. There is some in vitro evidence of activity against SARS-CoV-2 in infected Vero E6 cells reported with high concentrations of this drug. It's licensed in Japan and China for now for treatment of influenza. So primarily, it's an anti-influenza drug. Toxicities, there's a lot of toxicities with the use of Avigan that includes hyperuricemia, diarrhea, elevated transaminases, reduction in neutrophil counts. And there's also evidence of early embryonic deaths and teratogenicity observed in animal studies. So for as of this time, Favipiravir is still contraindicated in women with known or suspected pregnancy. It's also a CYP2C8 and aldehyde oxidase inhibitors that and hence there would also be a lot of drug-drug interactions when using this drug. So some trials that are ongoing that are investigating the use of Avigan. In the US, we have a randomized controlled open label proof of concept trial. And there's also another trial that's ongoing with the use of Favipiravir in patients with mild uncomplicated COVID-19. Regarding the dosage, I've mentioned some of the dosages here, but one pharmacokinetic simulation model suggested that a dose of 2,400 milligrams twice daily on day 1, followed by 1,600 milligrams twice daily on days 2 to 10 should achieve adequate Favipiravir trough plasma concentrations. So you really need to use a high dose of this antiviral before it exerts some kind of effect on COVID-19. But again, you have to balance it with the risks of the toxicities that goes with the higher dose. So some take-home points regarding Avigan. Efficacy and safety of Favipiravir for treatment of COVID-19 is not yet established. Given the lack of pharmacokinetic and safety data for the Favipiravir dosages proposed for treatment of COVID-19, the drug should be used with caution at such dosages. Favipiravir is also associated with QT prolongation, and some have suggested close cardiac and hepatic monitoring during treatment, as well as monitoring of plasma and tissue concentrations of the drug, and if possible, the active metabolite. Moving on to another anti-influenza antiviral is Umifenovir or Arbidol. The mechanism of action is that it inhibits S protein or ACE2 receptors. Hence, it's more of like a membrane fusion inhibitor on how it exerts its effect on COVID-19. It's licensed in China, Russia, Ukraine, and possibly other countries for prophylaxis and treatment of influenza. The dosage recommended for treatment of COVID-19 in China for adults would be 200 milligrams orally 3 times daily for no more than 10 days. The dosage used are being investigated in COVID-19 clinical trials would be pretty much the same dosing. It's not yet commercially available in the US, but the efficacy for the treatment of COVID-19 is not yet established at this time. Listed are some of the trials that are ongoing in China that's investigating Arbidol for its efficacy. One trial, which was an open-label prospective randomized multi-center study in 236 adults, showed that clinical recovery rate was greater in those treated with Favipiravir than with Umifenovir. And another trial that was investigating Lopinavir-Ritonavir in combination with or without Umifenovir found that Lopinavir-Ritonavir that there was better there was shorter time to conversion to negative SARS-CoV-2 and improvement in chest CT scans with a combination of Kaletra plus Arbidol. And lastly, another trial that was also done in China for 86 patients found no difference in clinical outcomes between patients treated with Umifenovir or Lopinavir-Ritonavir compared with no antiviral therapy. So again, it's still efficacy and safety of using Arbidol is still questionable. Another antiviral that's also being investigated is Baloxavir, which is an oral prodrug that is converted to Baloxavir, and which is an inhibitor of the endonuclease activity of a selective polymerase acidic protein. Again, it helps with inhibiting viral gene transcription. So the dosage from the protocol of 2 registered Chinese trials, it's 80 milligrams on day 1 and on day 4, and another dose of 80 milligrams on day 7, but not to exceed 3 total doses. No data yet to support use in the treatment of COVID-19, but again, it's another investigational drug. And on a more recent news, Russia is now about to launch use of Avifavir, which is a Favipiravir-based antiviral drug. This was a news article that came out just this Monday of this week on June 1, wherein Russia is about to launch found like good data regarding a randomized trial using with like 330 patients that found some efficacy with using Avifavir. And then they will be launching it within this week to use Avifavir for most of their hospitals there in Russia. So still more to come about if this drug would actually be a lot more effective than what from other antivirals being investigated. So, okay. And before we move on to the next group of therapies, anybody have any comments? No. Okay. So moving on to the next group of it's the supportive agents would be your supportive therapies, and I've listed all of them there. There's a lot of agents that are being investigated as supportive agents for COVID-19. So I've decided to just group them into 3 big groups depending on their drug class. So we'll start first with your disease-modifying anti-rheumatic drugs, or your DMARDs. And included in this list would be Tocilizumab, Sarilumab, and Anakinra. So Tocilizumab is a recombinant humanized monoclonal antibody specific for the interleukin-6 receptor. It may potentially combat cytokine release syndrome symptoms in severely ill COVID-19 patients. The initial studies that were investigating the use of Tocilizumab were pretty much in China. One single-arm observational Chinese trial involving 21 patients with severe or critical COVID-19 infection found rapid fever reduction and a reduced need for supplemental oxygen within several days after receiving Tocilizumab. Another study, which was a retrospective observational study involving only 15 patients, found that, however, that clinical outcomes were equivocal for the use of Tocilizumab. So another randomized multi-center study in China was trying to explore also on the dosing of how to give Tocilizumab. Initial dose in their protocol was to give 4 to 8 mg per kg infused over more than 60 minutes. And then you may administer a second dose after 12 hours. So because of some of the evidence of these initial studies, it then launched a global study in the U.S. and also pretty much around the world. That was a randomized double-blind placebo-controlled phase 3 trial, and this trial is titled COVACTA. It's being run by the manufacturer of Tocilizumab, which is Roche, in collaboration with the U.S. Health and Human Services Biomedical Advanced Research and Development Authority. The purpose of this trial is to evaluate safety and efficacy of Tocilizumab in combination with standard of care compared with placebo. And the dose here in this trial is to use initial IV infusion of 8 mg per kg, and 1 additional dose may be given if symptoms worsen or show no improvement. It's expected to enroll around 330 patients globally, including in the US, beginning in April 2020. So for some take-home points on this, NIH COVID-19 treatment guidelines panel states that there are insufficient clinical data to recommend either for or against the use of Tocilizumab in the treatment of COVID-19. The role of cytokine measurements in determining the severity of and treating COVID-19 requires further study. This is pretty much one of the drugs that we are using, that we are currently enrolled in as a trial site, which is Sarilumab Kevzara. So the mechanism of action, it's also an IL-6 inhibitor. It's a human IgG1 monoclonal antibody that binds specifically to both soluble and membrane-bound IL-6 receptors, and it has been shown to inhibit IL-6 mediated signaling through these receptors. It may potentially combat cytokine release syndrome and pulmonary symptoms in severely ill patients. It was initially formulated for subcutaneous dose injection at doses of 150 and 200 milligrams, and it was initially approved for the treatment of rheumatoid arthritis in the US back in May 2017, and several other countries as listed. So this is the trial is still ongoing. There's a phase 2/3 randomized double-blind placebo-controlled study being run by the manufacturer of Sarilumab, and in patients hospitalized with severe COVID-19. So still, the results of it is still pending evaluation at this time. NIH treatment guidelines panel states that there are insufficient clinical data to recommend either for or against use of Sarilumab in the treatment of COVID-19. Next DMARD that's being investigated is Anakinra, which is an IL-1 receptor antagonist protein. The IL-1 levels are found to be elevated in patients with COVID-19, and Anakinra may potentially or theoretically combat cytokine release syndrome symptoms in severely ill COVID-19 patients by inhibiting IL-1 secretion. So currently, there are no known published controlled clinical trial evidence supporting efficacy or safety of Anakinra in treating COVID-19. There was a small case series in France that investigated the use of Anakinra for 9 patients and found some decrease in oxygen requirements for these patients. There's currently phase 3 randomized open-label multi-center trial going on in Italy that's evaluating the safety and efficacy of using Anakinra compared to standard of care in reducing hyperinflammation and respiratory distress in COVID-19, which is still currently recruiting at this time. Moving on to the next group of supportive agents will be your anti-neoplastic agents. These would include Siltuximab, Baricitinib, Ruxolitinib, and Interferons. So Siltuximab is also another recombinant chimeric monoclonal antibody that is also an IL-6 inhibitor. It's primarily used for multicentric Castleman disease in HIV negative and HHV negative patients. But again, being an IL-6 inhibitor, it's pretty much in the same class as Tocilizumab and Sarilumab that's being investigated of whether it will have some efficacy with controlling the hyperinflammatory stage of COVID-19. One of the trials that's exploring the use of Sylvant will be the Cisco study in Italy, which is a compassionate use program observational case control study. In their study, they gave a dose of 11 mg per kg by IV infusion over 1 hour, and a second dose could be given per physician's discretion. This is still an ongoing cohort study, and the interim analysis so far shows that 33% of the Siltuximab treated patients improved. No clinically relevant change in condition was reported in 43% of patients, but 24% of patients worsened, including 1 patient who died and another with a cerebrovascular event. So other clinical trials evaluating Siltuximab in the treatment of COVID-19 currently are recruiting in Belgium and in Spain, and these trials are investigating whether a single Siltuximab dose would be already sufficient for treatment. Next would be our JAK1 and 2 inhibitors. So the first one that's being investigated is primarily Baricitinib, or brand name Olumiant. Mechanism of action disrupts regulators of endocytosis-associated protein kinase 1 and cyclin G-associated kinase, which may help reduce viral entry and inflammation. It inhibits JAK1 and JAK2 mediated cytokine release as well, so there might be, apart from being suspected to, theoretically being an antiviral, it can also be used as an anti-inflammatory. This is now another major trial that the NIH is also conducting. It's which is the ACT-T2. It's an adaptive randomized double-blind trial to compare a regimen of remdesivir alone versus a combination of remdesivir with baricitinib. So patients will be randomized 1:1. First group will be receiving remdesivir, and then the other group will be receiving remdesivir plus baricitinib, with the dosing of baricitinib to be given will be 4 milligrams once daily for the duration of hospitalization, or up to 14 days in total. So again, it's still recruiting, it's still ongoing. We still don't know the results to be further evaluated once it's out. And there's also another adaptive phase 2 or 3 clinical trial also ongoing in other parts of the country, in other parts of the world. The other JAK1 inhibitor that's also being investigated is Ruxolitinib. There's a phase 3 randomized double-blind placebo-controlled clinical trial also ongoing regarding Ruxolitinib, and another trial that's ongoing, the Rux-COVID-DVent, which is a more international or like worldwide multi-center study. So take-home points in general for Janus kinase inhibitors. The NIH recommends against use of JAK2 inhibitors for the treatment of COVID-19, except in the context, again, of a clinical trial. So at present, the broad immunosuppressive effects of JAK inhibitors at this time outweighs the potential for its benefit. Moving on, next will be your interferons. So interferons modulate immune responses to some viral infections. In vitro studies indicate only weak induction of interferon following SARS-CoV-2 infection, but there's still a possible role for interferons in prophylaxis or early treatment of COVID-19. Clinical trials are currently evaluating interferon beta-1A or interferon beta-1B, generally added to other antivirals for the treatment of COVID-19. So first type of interferon being investigated would be Aerosolized Interferon-a2b, which is not commercially available in US. However, early parts of the disease, the Chinese guidelines has placed this as a possible option for treatment of COVID-19. However, limited clinical data is still present to date. There was a retrospective study of 77 hospitalized adults in China that were given aerosolized interferon alpha-2b, and then comparing it with Arbidol or other drugs. And the time from symptom onset to negative RT-PCR result in throat swab appeared to be shorter in those receiving interferon alpha-2b alone or in combination with Arbidol compared with those receiving Umifenovir alone. So, but this was a small and non-randomized study. So again, the evidence is still being questionable. These are other trials that are investigating the use of interferon beta-1A, and as listed, and then they are comparing interferon beta-1A in comparison to being as a combination therapy versus hydroxychloroquine and ritonavir and other more antiviral combinations. And several more other trials using interferon beta-1B. I think there was this, yes, like over the last week, I think like Dr. Ayler discussed this study with us during rounds in the VA, which was the open label randomized phase 2 trial that was done in Hong Kong that explored this combination regimen of Kaletra plus ribavirin plus interferon beta-1B versus your control of just Kaletra alone. And this was also a study that was published in the Lancet as well. So in this subset of patients initiating treatment 7 or more days after symptom onset, there was no significant difference in time to negative RT-PCR result that was seen. However, there was like shorter median time from treatment initiation to negative, and there was an earlier resolution of symptoms and shorter hospital stay. So take-home points regarding interferons: efficacy and safety of interferons for treatment or prevention of COVID-19 is not yet established. Relative effectiveness of different interferons against SARS-CoV-2 is not yet established. And NIH recommends against use of interferons except in the context of a clinical trial. Next, next group of supportive therapies would be your vasodilators. Nitric oxide has been found to have is a selective pulmonary vasodilator with bronchodilatory and vasodilatory effects. And there is some in vitro evidence of direct antiviral activity against SARS-CoV-1, but not yet regarding SARS-CoV-2. In a small pilot study conducted during the SARS outbreak, treatment with inhaled nitric oxide was found to have reverse pulmonary hypertension, improve severe hypoxia, and as we already know, it's also something that's also being used for ARDS in general. However, there are still no published studies evaluating use specifically in COVID-19 patients. Epoprostenol is also another selective pulmonary vasodilator that may be useful in the adjunctive treatment of ARDS, and it is suggested to be an alternative to inhaled nitric oxide due to its similar efficacy, lower potential for systemic adverse effects, lower cost, and ease of delivery. It can substantially reduce mean pulmonary artery pressure and improve oxygenation in ARDS. However, there are still no studies evaluating use specifically in COVID-19 patients. So inhaled pulmonary vasodilators in general, the NIH recommends against the routine use of inhaled nitric oxide in mechanically ventilated COVID-19 patients with ARDS. However, they place a little bit of a disclaimer. A trial of inhaled pulmonary vasodilator as rescue therapy may be considered in mechanically ventilated adults when hypoxemia does not improve despite optimized ventilation and other rescue strategies. And lastly, this big group of supportive therapies would be your azithromycin, corticosteroids, and sirolimus. So I believe I'll skip some of the azithromycin part since we discussed it much in conjunction with hydroxychloroquine. So corticosteroids are potent anti-inflammatory and have antifibrotic properties as well, which may prevent an extended cytokine response and accelerate resolution of pulmonary and systemic inflammation in pneumonia. Observational studies have suggested that corticosteroid use in patients with SARS, MERS, and influenza was associated with no survival benefit and possible harm. This was a retrospective observational single-center study that was the initial study in China. It had 201 patients, and they found that methylprednisolone or SOLU-Medrol appeared to reduce the risk of death, but their dosage was not provided at that time. Another retrospective observational single-center study in China with 46 patients found that the use of methylprednisolone was associated with improvement in clinical symptoms and a shortened disease course. And again, another study in China that's going to compare use of methylprednisolone in conjunction with standard care in patients with confirmed COVID-19 infection. So in general, several institutions, WHO, CDC, NIH, and IDSA generally recommend against the routine use of corticosteroids, however, because of the lack of evidence to support efficacy and safety. This for the treatment, unless it's indicated for another reason. Again, there's another paradox with these recommendations. So NIH states that oral corticosteroids used for the treatment of an underlying condition prior to COVID-19 should not be discontinued. So if you have patients that have adrenal insufficiency or it's being used for like rheumatologic diseases, do not discontinue their steroids or have the specialist assist with dose adjustment. IDSA suggests against using corticosteroids in hospitalized patients, but may be used in the context of a clinical trial again. Findings from observational studies suggest that for patients with COVID-19 who progress to ARDS, methylprednisolone treatment may be beneficial. However, the results for other corticosteroids is still questionable. And again, observational studies are not really the studies with the best justification for efficacy. So the other one is another supportive therapy being investigated is sirolimus, which is an mTOR inhibitor. Theoretically, it has a possible clinical application for the reducing hyperinflammation. However, there are still no studies available at this time to suggest it to be a mainstream use. There are several trials ongoing that's investigating the sirolimus as well. Okay, so lastly, the other big group regarding therapies for COVID. It's a really long list, but we'll touch a little bit about COVID-19 convalescent plasma in this last part of the lecture. So COVID-19 convalescent plasma is plasma obtained from patients who have recovered from COVID-19 that contains antibodies against SARS-CoV-2 that may provide short-term passive immunity to the virus. And theoretically, such immunity may prevent or contribute to recovery from the infection. Although there is some evidence that suggests possible benefits from use of convalescent plasma in patients with COVID-19, available data to date are largely from case reports or series. Confirmation from randomized controlled studies is still required. I listed there just some of the studies that were done in China regarding the use of convalescent plasma. In general, though, these studies had like a very small patient population. So again, it's hard to try to generalize it to a bigger population at this time. There are now multiple clinical trials that were initiated in the US and other countries to evaluate use of COVID-19 convalescent plasma in various settings, such as as post-exposure prophylaxis and treatment of different stages of the disease as listed there. And these are all available in clinicaltrials.gov. So 3 available pathways for administering or studying the use of convalescent plasma will be either through clinical trials, and then the FDA also started this National Expanded Access Investigational New Drug Protocol for patients with serious or immediately life-threatening COVID-19 who are not eligible or are unable to participate in clinical trials. So access will be through participation of acute care facilities under an IND that is already in place. And they have a link there. I placed the link there so that you can also explore further on how to get convalescent plasma. There's also a single patient emergency IND. Again, that's another pathway that's included in that link that provided on how to get it for a single patient. So patient eligibility for convalescent plasma per National Expanded Access Treatment Protocol. Patient should have severe disease or life-threatening disease, which with the following criteria as stated. So for donor eligibility, it should be the donor should meet the following criteria: laboratory confirmed evidence of COVID-19, complete resolution of symptoms for at least 14 days, and a negative result for COVID-19 is not necessary to qualify to be a donor. And if measurement of antibody titers is available, FDA recommends a neutralizing antibody titer of at least 1:160. And a titer of 1:80 may be considered acceptable if an alternative match unit of plasma is not available. In general, though, the NIH states that there are insufficient data to recommend for or against the use of convalescent plasma in patients with COVID-19. Currently, there are no convalescent blood products currently licensed by the FDA, and it's still regulated as an investigational new drug. So issues that require further evaluation regarding the use of convalescent plasma, appropriate criteria for selection of patients to receive convalescent plasma, optimal time during the course of the disease to receive such therapy, what is the appropriate dosage, and when is the optimal timing of donor plasma collection in relation to recovery from COVID-19, most appropriate methods of antibody testing, and what is the minimum titers of SARS-CoV-2 antibody and convalescent plasma that may be associated with clinical benefits. So a lot more issues still to investigate. Other issues also would be the logistics of obtaining and processing, storing and distributing the convalescent plasma. For right now, the FDA had already started some guidelines to it, but whether it can be implemented effectively is still to be known. And the potential risk associated with COVID-19 convalescent plasma therapy, as you all know, like inadvertent transmission of infectious agents, allergic reactions, thrombotic complications, TACO, TRALI. There's still a lot of side effects from convalescent plasma therapy that needs to be further known. Since we are in the topic of antibodies or immune-based therapies, there's also immune globulin that's also being investigated. Immune globulin is basically derived from pooled plasma, and it's more like a concentrated form of convalescent plasma, in other words. And immune globulin preparations containing antibodies specific to SARS-CoV-2 may theoretically help suppress the virus and modulate the immune response to COVID-19 infection. As of now, though, we don't know, right, like from all the plasma that's being with all the plasma that's being collected, we're not yet sure how much of those would actually contain COVID-19 antibodies, and how much of that plasma would you actually need to really pool together to come up with this concentrated immune globulin version of a COVID-19 IVIG. So that's still being investigated. So regarding the use of IVIG, it has been used in the treatment of SARS in some studies. And Cao and her colleagues also in China, there were some case reports in China that tried to investigate as well whether using IVIG would have some would have some efficacy in treating COVID-19. However, this clinical experience in China, however, has like low number of patients. So again, generalizability of these studies might not be applicable at this time. So in general, NIH again does not recommends against the use of commercially available IVIG, except in the context of a clinical trial. And again, as I said, like this current IgIV preparations are not likely to contain SARS-CoV-2 antibodies. So again, it still needs to be investigated, or maybe perhaps we just need more time to have that herd immunity develop so that we can pool together a large, a concentrated sample of SARS-CoV-2 antibodies together. Okay. Now, as we know, there's also a hypercoagulable state that's observed in severe COVID-19. And these coagulation abnormalities are far-ranging. It can be DIC, you can have venous thromboembolism, elevated D-dimer levels, high fibrinogen levels, microvascular and macrovascular thrombosis. The true incidence of this hypercoagulable state, however, is still not yet known. And it pretty much varies with different severities of the disease. And the pathogenesis of COVID-19 related coagulopathy is not yet known at this time, but it's suspected to be related to inflammatory response to viral infection. Given this hypercoagulable state, in theory, anticoagulant therapy may possibly reduce the risk of thrombotic complications and improve clinical outcomes. There's just limited data from a retrospective study in China by Tang and his colleagues, wherein they found reduced mortality in COVID-19 patients with severe sepsis-induced coagulopathy or markedly elevated D-dimer levels 6 times above the upper limit of normal, who received prophylactic anticoagulation, such as your low molecular weight heparin or unfractionated heparin. This then launched several more prospective randomized open-label studies that are exploring the use of anticoagulation in treatment of patients with severe COVID-19 infection. In general, NIH recommends that patients with COVID-19 should receive the appropriate VTE prophylaxis, not unless it's contraindicated. Other organizations also recommend, such as the International Society for Thrombosis and Hemostasis, American College of Cardiology and American Society of Hematology also recommends that patients with COVID-19 receive prophylactic dose low molecular weight heparin unless contraindicated. WHO also recommends either low molecular weight heparin or unfractionated heparin in patients with COVID-19 unless there are contraindications. So these institutions pretty much advocate the use of prophylactic dose of your anticoagulants, but whether or not they would need therapeutic dosing, it's still being investigated. And lastly, regarding thrombolytics, tissue plasminogen activators, there are several case series, again, done in China that initially saw some benefit with using TPA. And currently, there's an open-label randomized trial that's exploring TPA as well, and results are still to be determined. TPA or thrombolytics in general is proposed to be just as a salvage treatment, but not the first-line treatment. Several institutions like Beth Israel, University of Colorado, and Denver Health are currently testing this approach of using TPA as a salvage treatment for COVID-19 patients. Preliminary findings from the first few cases reported an initial but transient improvement in PF ratio. But again, this is still preliminary. We still have to wait for the final results. NIH states that current data are insufficient to recommend for or against the use of thrombolytic agents, except outside the setting of a clinical trial, but again, can be considered if in the context of a clinical trial. And the same with the American Society of Hematology states that treatment of the underlying pathology is paramount in COVID-19 patients with coagulopathies. Supportive care should be individualized, and standard risk factors for bleeding should be considered. Okay, so there's still a lot more therapies that are still being investigated out there, but these are the major ones that I thought were good to include in this lecture. Okay, and that's pretty much the end of my lecture. And now I'm opening for the floor for discussions. Questions?